loud. What I should do is play the that weird jazzy music in between, because when it turns off, people know oh, heads up.
Oh, time to get our
exactly
back in the room.
Exactly. Is there any particular way you'd like me to introduce you, by the way? I mean, everyone knows you, so
but that's very kind of.
I think that's true. All right, here. Get this going here.
I've been doing this too long.
Yeah, doing great so far. I struggle with OBS, but I was able to get it. I Zoom file formats. Okay, we just use Cloud as well, just to eliminate having to muck with files. So
Okay.
Yep. I appreciate the help though, and this is working fine. It looks like I did a quick test recording, and it seemed like audio came through. So
Perfect.
Yep. Thank you. All right, everyone ready? Everyone's ready to take your seats. We'll continue with our programming.
That happens when bankers don't see each other, and they're very social.
I have to expect them to all sit in their seat and behave now. Yeah. They might listen to you more than they listen to me, though. All right, everyone, take your seats. We're gonna go ahead and introduce our next speaker, or actually set of speakers. Everyone's found the coffee. Okay.
Sort of, kind of.
You're starting to get there. Yes, indeed. Okay, so we'll go ahead and move on to our next presentation. So it's my pleasure to introduce Colleen Aronson, which feels very performative to introduce her to the current audience because everyone I think knows her. She's the Director of Transfusion Services at Advocate, covering Illinois and Wisconsin areas. I believe you were past ILABB president as well.
Yes,
right?
yes.
And also you were an ABB program chair. You just moderated a talk on mass casualties this
Yes,
past
yes,
year,
we
so
did.
I'm sure many of us saw that. She's just generally been a fixture of the Illinois transfusion community, and this talk proposal is really highly anticipated. It was originally submitted, I think, for our fall series, but we decided that it needs much more than the 12 minutes we tend to give talks in our fall meetings. So we pivoted over to here, and we're really grateful that she's going to be presenting to us, she and her colleagues, and I'll let you take care of the rest of the introductions then.
Thank you so much. As Dr. Carl said, I never have answers. I always have a lot of questions. So can you guys hear me if I put that down? So
It's a little bit quiet.
okay, I'll just, is the hand mic better?
That one doesn't work pretty well.
Okay, this one on?
Flip it on, and then
There
3
we go.
seconds, and it should be good.
Everything okay?
Much better.
Got it. So I have a bad habit of reaching out to a few friends here and there in the Chicago area and asking my stupid questions. So I picked on Ricardo and Gale and Ignacio, who are definitely know me for far too long, but also have the same kind of questions. So we did put together an abstract, like Dr. Carl said, and it was basically just a list of all the questions that we had. So then ILABB asked if we could go ahead and present this as a bigger session. And how do I get to the next slide? I just don't know where to hit. This one, got it.
Oh yeah, I'm sorry, I don't think it's a touch screen. So if you want to just click to advance, or you can use the arrow keys.
That'll work.
Yep.
Thank you.
Or a space.
Space bar. It's bigger. Yeah. So just a little bit about the objectives that we have. Again, we're going to talk about pre-hospital blood transfusion. It's something that everybody seems to be talking about lately. And discuss some of the initiatives at some of the different hospitals and the different state restrictions. Evidently, there's also Cook County, or actually the city of Chicago has their own guidelines as well. And then just a discussion session to just see what everybody thinks, where they're at, and what they think they're going to do for a program or a possible process to put into place for their future. So background about myself. Again, I'm the technical director for the Midwest region for the Advocate Health System, which includes most of the eastern side of Wisconsin and Chicagoland area. 26 sites. Ranging from 10 beds, why we opened a 10-bed hospital, I'll never know, and put a transfusion service in it, and up to over 700 beds. We have 5 level 1 trauma centers in the Chicagoland area and 2 level trauma centers in the Wisconsin sites, and 2 children's hospital locations within that, and 20 sites do deliver babies. So we're busy. Why the push for pre-hospital transfusion? I blame the military. They love whole blood. They think it's the best thing ever. So I guess what's old is new. We used to do whole blood eons ago, but once we got bags that we could split, we made components. We're like, why are we going back to whole blood? The unit that people are looking at is low titer group O whole blood. So low titer means anti-A and anti-B titers are low enough so that you can give it to anybody, any blood type. It contains all the components in one bag, which a lot of studies show 1:1:1 ratio of red cells to plasma to platelets. This is all in one bag. It's usually good for about 21 days. So it's not too hard to move back and forth, and you can store it further away than in the blood bank. There are most units that are out there that the blood suppliers supply are Rh positive. So they're O positive units. So you do have to have considerations for females of childbearing age. But there's a lot of literature on maybe you don't. So that's something else that's definitely coming. The other piece about having an additive red cell, if you're giving four red cells, which is our cycle, there's about 110 mLs of additive solution in almost all the red cells. So you're giving an extra 440 mLs of crystalloid solution. So that's why whole blood is not diluted out. So that's that other reason that the military likes it. So yeah, we're just trying to mimic whole blood as much as possible. Regulatory concerns, hot off the presses. Just got mine last week. There are new standards out from the ABB, emergency pre-hospital and scheduled out of hospital transfusions. So we've been looking for guidelines. We've been kind of making it up as we go along and hoping we meet the guidelines, but they will be effective July 1st. So a little plug for ABB, go get your standards. State and municipals, different EMS services have restrictions. So you have to look at those guidelines. The FDA CFR requirements are still apply, just like they always do. Circular information is referenced throughout the new standards. So we still have to comply with all the CFR requirements as well. There are concerns about reimbursement restrictions through CMS. I'll talk about that a little bit later. And a lot of the places that are getting blood out to the different EMS services in the country make sure that they have an agreement with the EMS service that they're supplying to make sure who's doing what and how and why. So very good reason to have that written up and agreed to before you get started. Again, the new standards just came out effective July 1st. So if you need any help, I recommend highly going through that. The quality system essentials, which are the same for almost all of the standards out there. They're very, very much the same: validation, equipment, and all of that stuff, document retention and everything else. The two specific scenarios are called out in section 5, which is where most of the meat of most standards are. The pre-hospital activities are first, which in the draft, they were the opposite direction. So it confused me when I first looked at it. I'm like, oh, okay, they switched them. Pre-hospital stuff is 5.2 to 5.43, and the out-of-hospital activities are 5.5 to 5.13. Is anybody sending blood outside their hospital to an outside facility? Yeah, so it's, again, it's one of those things to make sure you have agreements that you know where the magic line is. If you're doing that kind of stuff. So it's just some definitions that are in the standards. Pre-hospital setting, urgent or emergent care provided to a patient before arrival at the hospital, including but not limited to the point of injury in a road ambulance or a helicopter. So they can, I did hear one story from EMS that they hung a unit while they extricating the individual because they didn't think that they were going to make it till they got them out. So that did save their lives. They really felt that that was a big thing, that they were able to give the unit while they were still extricating the patient. Transfusion administration service. We have a type and screen. We call it a TAS. So every time I see TAS, I think of a type and screen, but it's transfusion administration service. So that's the service provider responsible for receiving and transmitting orders of blood for transfusion, transporting the blood to the transfusion site, performing the transfusion, monitoring the patient during the transfusion, reporting outcomes, and ensuring the traceability of the unit is maintained. So that's the person in the ambulance or whoever is taking the blood with them and doing the transfusion. Okay, transfusion service, that's probably the rest of us. The facility that performs one or more of the following activities: compatibility testing, ABORH confirmation of the whole blood or red cells prior to the selection and issuing of the blood and blood components to the intended recipients. And transfusion service do not routinely collect blood or process whole blood into components. I'm gonna keep the next one. Some of the changes from the draft to the final, they did rearrange. Like I said, they put the pre-hospital before the out-of-hospital, which was not that way. The other big thing that I'm just going to call out, the draft required 2 identifiers like we always use in blood bank. They have changed that to be a unique identifier. I'm sure that was a lot of feedback from the EMS teams that they usually don't get 2 identifiers. They probably have a set of numbers that they just use for those patients until they get them to the hospital, and just transfer those numbers so that they can connect all of the information. So this is one of my favorite maps. If you look and you can see that there's a lot of blue and flames. Those are all places that are doing remote transfusion, that have EMS services that are doing it. You can see there's quite a few gaps. But Southern Texas, right in that one blob in Southern Texas, as well as the Carolinas and Virginia have quite a few, as well as Florida. So the crosses are Red Cross sites. There's Vitalant shown, and BCA centers are the other indication on there. This is from a website called prehospitaltransfusion.org. So you can kind of tell the perspective based on the title of the organization, but it's from an EMS organization. Product handling, again, we always have information about visual inspection. It's required at the time of receipt, prior to administration, and upon return to the blood supplier. So very similar to what we do when we transfer units back and forth, or if we issue them and return them. Labeling must indicate the compatibility testing has not been performed. We all use uncross-match labeled for most of our MTPs or emergency release process, so that's not something new. We should be able to handle that. Administration must include infusion devices and ancillary devices. So again, blood infusers or blood warmers. I have heard that some ambulances do have blood warmers on board. So they do need to keep track of that information of what blood warmer they're using while they're giving the unit. Again, the transfusion administration services has to provide patient samples, empty bags, and segments so that follow-up testing can be performed. I do have a little concern about labeling of a blood sample on an ambulance or on a helicopter, because they don't necessarily follow our site-specific requirements for labeling. I think many sites, even though this is in the standards, I think a lot of sites are going to say, wait till they get to the emergency department and then draw samples so that you have positive ID. If you only have one identifier, that's a little concerning. So I'm not sure how that's going to work. But the empty bags and segments, again, I don't think all of the sites that are currently doing this are getting the segments or the bags back. It depends on if you're the one issuing the units, you're probably reserving segments. But if it's going to a different location than the originating facility, it might be a little fun and exciting to figure that out. Temperature, our favorite thing to worry about is temperature. So our favorite thing from the FDA, storage versus transport. Storage, we can go 1 to 6. Transport, we can go 1 to 10. So the definition from the FDA is always, if you take a cooler to the OR with blood in it, and then you give it to them and they put it in a refrigerator, that cooler is only being used for transport. But if you take that cooler with blood in it and set it next to the wall in the OR and leave it there, that's storage. So be very careful how you validate any cooler to make sure you're meeting the requirements for that quote unquote storage versus temperature. And it's called out also for storage, you're supposed to take temps a minimum of every 4 hours. You need to determine if you're going to have a refrigerator remotely and then pack a cooler. How are you going to do that? Or is the EMS service going to do that? There are these coolers that are like $11,000. APRUs, I think they're called, is the abbreviation. They are basically plug them in, take them on the ambulance, plug them back in. They have a temperature monitoring system with it built in, and a graph that you can download remotely. So if you're willing to pay the money, they're out there, but somebody's got to commit to that price. EMS medical director, again, there has to be an EMS person who has an MD or a DO who oversees the whole process and approves all the procedures, including the ABO components, the uncross matched units, what constitutes the appropriateness to transfuse, including an adult and pediatric situation. And then again, somebody who needs to sign the emergency release. I don't know about anybody here. Anybody else have problems getting emergency releases signed? Yeah, okay. So add this to the complexity. What I've heard from places who are doing this, we have sister locations in Carolinas at Wake Forest. They do it on ambulances, and actually the medical director, the EMS medical director, is also one of the ED docs. So the ED docs usually sign it. They want to continue having blood remotely pre-hospital, so they are willing to be the ones to sign it. So again, you just have to talk with the right people probably to figure that piece out. You do have, there was a listing in the draft to notify the EMS medical director of any abnormal stuff, but I think they took it out because you really probably want to notify the treating physician, the current treating physician, rather than the one who kind of just signed off bringing them in. Okay, this is my favorite map. You see a big black zone right there in the middle. So the black states are the ones that EMS is currently not allowed to initiate or spike a blood product. Illinois is one. Okay, so it takes an RN in the state of Illinois to be able to spike a unit in transit. Ricardo sent me a thing from, I think it was an older thing, that even in Chicago previously, they couldn't even take a patient that already had blood hanging. That is not the case any longer. They just kind of didn't say anything in the updated version. They just kind of left it. But most EMS, if they're transporting a patient from one site to another, if a unit is already hanging, they can take the patient. They just can't spike the units. I cover Wisconsin too, and you see that one's red. So this is a hot topic, and my friends up north in Wisconsin. We're implementing a process up in Marionette. It's in the middle, almost to the Upper Peninsula of Michigan. So you see Michigan is black. So my big question is, if they go across the state line to pick somebody up, do they have to wait till they get back into Wisconsin to hang the unit? We'll see. But again, in Illinois, it does require the nursing staff, and the EMS is really part of the transportation, the Department of Transportation. They are not part of Health and Human Services. So it's a different perspective, but all the states license their EMS, you can see, by state. Okay, look back and fatality notifications. You still have to know how to get that connection from beginning to ending, from vein to vein. So if there's ever a fatality or a look back, you have to be able to have that information for that patient. A lot of times, if the unit starts out from the blood center, they may or may not know where the patient ended up. Getting all of those things connected is really important. Fatality investigation, just like any other thing, if there's a fatality associated with the transfusion, we have to notify the FDA. It's part of the CFR. I don't know if we would always know if it's the transfusion that was part of the fatality or the trauma event, but we'd have to sort that out as part of the investigation. Utilization wastage, there is a requirement to monitor the blood wastage and utilization by the different areas. Again, most of these units are going to be O pos, maybe some A plasma. Again, you also have that guideline that your EMS medical director put together for what was appropriate use. So you do need to make sure that once you have that transfusions, that you're reviewing it, making sure it was given appropriately. And then a lot of education, not only about storage and wastage, but also continuing education for meeting CAP requirements for transfusion and transfusion reaction recognition and process blood administration. That's always an annual thing from CAP, and these people are transfusing, so you have to keep them up on those things. The other thing I talked with my friends down in Carolinas, they also said that the threat of taking it away, they're very good about not wasting units because they don't want to lose the opportunity to have those units sitting there for them. So if they start losing units and wasting them, you can kind of say, okay, that I'm taking it all away from you if you can't manage it appropriately. Billing. Currently CMS does not allow EMS services to charge for the blood products. Again, they're part of transport. They're not really part of Health and Human Services. So there is a proposal for the new EMS section for 2025 to CMS to have that be a possibility. It's also what they call Advanced Life Support 2. The ALS 2 is the highest category that they can bill for. So some EMS services that are supplying blood are just pushing the pricing up on that service to include the cost of the blood overall. The blood that is being used within the system, again, if the patient comes into the hospital, very often we give a ton of units for an MTP. They all kind of fall under a DRG, so you may or may not actually recoup the cost of all those units anyway. Computer tracking. This is the questions I have for a lot of the stuff. If you're issuing tracking from a location, you probably want to make sure that you know what that location is and you can show it in your computer system. So you might have to build another location to transfer it to, or to at least track it somehow that it went there. The other thing is, if you have a patient that comes into your site, the patient's probably going to get registered. But what if you weren't the one that originated the units? How do you get that patient information? Or if that patient, you issued the units and the patient goes to another site, how do you get that patient information into the computer system? What cross matches do you do? A lot of questions about that. You need a process to really recognize the demographic information for that look back and tracking. You need to make sure that the EMS has all of the information as part of the blood administration. And how do you get that information to you? Again, that final disposition you have to show. Should you bring those units? If it wasn't your units to begin with, do you bring them into your computer system? Or do you just do it on downtime, but then do you bill for the testing that you did? Who's billing for the units if they come from somewhere else? I mean, there's a whole can of worms that I'm not sure we have any of the answers to. This is probably more the scenario that we're going to see in Illinois. Blood is being moved with the patient, so received with the patient. So if you have a patient, especially if you live on the edge of Illinois with Indiana or Wisconsin, you may see blood coming in with patients pre-hospital. I know Christ said that we talked to the trauma doc down at Christ, and he's like, oh yeah, Indiana, they're sending them in with it. So they're seeing it. But again, what are you likely to see a patient? Again, the guidelines aren't really specific. It doesn't really talk about transferring patients with blood products, but that's probably what we're going to see, especially a lot of the helicopters, even in Illinois. What's the one, Gale? Lifestar. They have nursing staff. So they do transport blood products with their patients as part of the ambulance service on the helicopters. I think a lot of the helicopters have nursing staff. So if you're involved with that Lifestar organization or one of the other helicopter organizations, you may get requests for blood to go with the patients. And then it's a whole thing of how do you get your cooler back?
it's not to interrupt, but you don't know. What happened at Advocate Trinity,
Yeah.
issue went to the ER, all of a sudden they're on their way to Christ with our units.
Yeah, and you don't even know they took them. They just ordered them like regular units and then grabbed the patient and went. Yeah, yeah, yeah. Again, we do need to make sure that we have some way of tracking the patient, whether we issued the units or whoever issued the units, so that you can do the follow-up for a look back or a recall. I don't know about anybody, but we get recalls all the time. Again, and then what site is going to, who's dealing with the blood product, which site is going to be issuing it, and who's going to be tracking it or crediting it. There's a lot of questions about all those kind of pieces. So again, just a quick summary. Pre-hospital blood transfusions are becoming more and more common, and more sites are being asked to supply units. Current guidelines don't address everything. They give us a start at least. So always start with what you have. Use the new standards as much as possible. I think it's going to help you at least get some ideas. Talk to your friends who might be out of state and who are dealing with this. And having talked to a couple of the EMS people in the Chicagoland area, they're pushing hard to try and get this to be approved for Illinois. So it's not a matter of if, it's a matter of when they're going to have this come in our direction. You know, we're kind of spoiled in the Chicagoland area. We have so many level 1 trauma centers close by, but downstate, I don't know what they're doing. South of 80, I have no idea how they're handling these patients. Because if they have a car accident in the middle of, you know, Dixon or somewhere on the way down to St. Louis, we drove down to St. Louis, there's a lot of cornfields. I don't know what they would be doing out there to help these patients, because they're not allowed to spike units. So it's not a good situation. We're going to have a roundtable discussion. I did want to just really quick, there's a couple handouts that you were given when you walked in. Thank you, Ignacio. He put together just a couple workflows of pre-hospital and then one for transfer that might also give you some ideas to think about as you go through things. But I'm going to go ahead and I'm going to call up my friends here. Ignacio, I can never say your last name. Bustamante Murcia. I killed it. That's good enough. Okay. Ricardo Sumugod, which I always mess his last name up too. So he's used to that. And Gale Suwe. Ricardo's at, I'm sorry, Ignacio's at manager at Endeavor Health. And Ricardo's at Northwestern Medicine. What's your official title now? You're not blood bank, you're director over the whole lab. And Gale is also operations director out at Loyola. If you guys want to come up, we're going to go ahead and just look at the questions that I did set some on the table, and just looking for microphone. There you go. And I'm just going to walk around and see if anybody has comments or wants to share any of the things that they have had at their site. But the first question, is your site being asked to send blood with patients as part of a transportation from one site to another? How many people have been asked to send blood, or as Gale said, find out later that blood has magically gone? Yeah. And what have you guys done about it?
Just a quick overview or definition. So we're looking at out of hospital in pre-transfusion. So if you think of out of hospital, it's almost like the umbrella administration of blood in a setting outside the hospital. Could be an infusion center, could be a dialysis, if you think that way, or if we think of pre-transfusion or pre-hospital transfusion, that would be en route or during transportation. So it should be, if we think about those two concepts, right? Because when we think of out of hospital, sometimes we're like, okay, dialysis, I don't mess with that, or at home, we don't do that. But just to get you thinking. Thank you.
So I'm gonna pick on. Go ahead. Just how are you guys handling when you get calls for units to go on vacation?
Just as much documentation as possible, give them the paperwork that needs to be signed, you know, the emergency releases and that kind of stuff. And then following it, because we usually have the price So follow the units, make the phone calls. Just make sure.
And are you sending it to cooler?
Yes,
I need your cooler back.
we usually call them and sort of gotten it back. So,
Yeah.
it may take a few days, but we'll get it back.
Okay. Anybody else have a process that they're working on or have been stuck sending units? Yeah.
So do you currently have a procedure in place for these type of scenarios? Because sometimes we just come up with, hey, this is what we'll do today, and it will work, but do you actually have something in place to address this pre-hospital or
Yeah, you
hospital
have
procedure?
right?
Yeah, so Loyola Medicine is comprised of 3 hospitals, and they're quite often transferring from smaller to Loyola. So Loyola has a policy about receiving, admitting patients who already have blood hanging or have blood that if they have blood hanging, we get that information, make sure it's in the trauma chart. If we have units they have not used, our policy is on the blood bank, and we probably throw them away because we don't know the provenance of those units. So that's something that I think we need to think about as a group. What would we need to give us comfort level to accept that unit, bring it into inventory? Because hypothetically, if I'm an ARC customer and the sending hospital was an ARC customer, they could transfer to me in blood. And so we could transfer the billing, shipping of the unit, no problem. I'm sure Versity and Vitality can do the same thing if you both are customers of the same blood supplier. The question is, what if it's a different blood supplier? I don't have a contract with them. Moreover, how do I know what the temperature is? If we can solve the temperature issue, and I have records, I have that indicator that says the unit's okay, I could hypothetically bring it into my inventory. What does that look like?
Yeah, and that's kind of the next question that we have, you know, if you get a patient in with extra units, what are you doing with them now? Garbage? Okay, these are low cost units that we, or ONEG, that we scream and cry for the blood supplier all the time, that we never have enough of, and we're throwing them in the garbage. So it just seems like a big waste to all of us, that we can't do something. Again, most of them come in a validated cooler. You don't know it's validated, but if it came from the blood bank, it's a validated cooler. All the EMS coolers, all the places I talked to with implemented pre-hospital, they are, the blood bank transfusion service is validated. No one trusts everybody else. Transfusion service always wants control. So those coolers are validated.
Maybe we can send a validation
Yeah.
documents with the group.
Or
And then
like,
it's just action. So you should check the year standard, so I'm just gonna give a feedback on the Northwestern community, so in the 9 hospital systems that we have. The academic medical center, of course, is in downtown Chicago, so we don't really rarely do get some units that's transferred and goes to the garbage. Our once community hospital in McHenry actually had a procedure, so they're contracted with LifeNet, who's now Air Methods. So they actually prepare a cooler with 2 ONEG, RBC, and 1 liter, group 8 liter plasma in a cooler, and that gets cycled every 24 hours. So every morning, a staff from the LifeNet EMS service, the helicopter, they come and pick up that cooler, and then the next day they bring it back, and then it gets recycled. So they go with it. So I think it's rarely transfused, but it's transfused. We have no idea what they're giving it to. So it could be probably, so it's in McHenry County. So I don't know if it crosses to Wisconsin, or what is the trauma center up north. So probably that, you're using Candel, they're using Candel, so if you get them, we validated them, so you can use them. And then maybe we can bill you, but.
So for me, I mean, yeah, the coolers are validated, but so are my NTP coolers. How often do I get NTP coolers back with the rest sell at 12 degrees? So my issue is not the cooler, my issue is how do I know that unit stayed at 1 to 10 degrees well?
That they left it in the cooler instead of pulling it out and setting it next to them while they were.
That's what I need some level of proof that the one that I have in my hand wasn't being maintained.
Do you guys use temp indicators?
Yeah.
I mean, we do, but I
Yeah.
don't know.
Yeah, does everybody trust it?
So, and here's the thing, when I was at the maternity, we issued two to the ER because it was that we weren't necessarily setting them up a temperature indicator because
Right.
we thought they were gonna be eminently transfused. We didn't know that they were gonna hang them, set them up for the price, and on price, but those units are hanging. So I don't worry about units that are being transfused, and in fact, when I talked to one of the nurses, she is an RN from Lifestar, she said if they have multiple units, they really try to slam them in the patient before they get to the receiving ER because they know they're gonna be discarded.
Yeah.
So do we have any level 1 trauma centers represented? Okay, what is your current process in this particular case scenarios as far as maybe getting units or maybe you sending units out to other hospital systems?
What do you do?
You know very well you want. A lot of times, we don't even know that they got these, if they're in the ER or they stay down there. The blood banks rarely notified that somebody got blood in transport. So.
The black curtain. And I think that's another piece that as this gets crazier and crazier, you need to have that conversation with your town doctor, your emergency room doc. To say, hey, we need to know. Again, I'm working on a process for our friends all the way in Marionette, Wisconsin. They're coming up with an ID ban, back to the blood bank ID bans. I hate to talk that, but, they have one identifier number so that they can slap it on the paperwork if they have paperwork. But they also, have put the phone number for the facility that issued the units so that you can call them and let them know that you received a patient with a band on saying that they got transferred. You know, the other piece that somebody mentioned and talked about was, what if there's a transfusion reaction? You don't have a pre-transfusion sample, I don't know, but we have a lot of trauma centers, we rarely get pre-transfusion samples on those trauma patients. So we get patients that have mixed field because they've gotten blood from another site, or they've got blood in transit. But, you know, those are the other things you have to think about, once you do get sampled, what is your blood results gonna look like? And what if you do have transfusion reaction? You're not gonna have a pre-transfusion sample. I think that's the reason that ABB, the standard asks for samples was so that you have pre-transfusion, but again, the labeling on it, it's kind of questionable.
Just a question, are there cases where more than one unit is being sent at a time? And also, part B is whether are there more than one patient getting transfused in the same event?
So again, I'm gonna lean on my friends from Wake Forest that we've talked to, because again, we have no experience, and they have about a year and a half experience. They routinely issue 2 whole blood, per ambulance or 2 helicopter. Rarely do helicopters have more than one patient in it that they can deal with at a time, they can add another helicopter and other ambulance service. The EMS that they distribute to, they are not putting them on the ambulances in the Wake market. They are actually giving them to the EMS supervisor, and if they call and say they need it, then it's their job to transport that cooler to that location. Other places are putting them on every ambulance that they have. I think up in Wisconsin, that's what they're doing. So there's a lot more blood out there floating around, which means a lot more monitoring and a lot more rotating units back and forth. So it's a little bit more chaotic, if you ask me. They try to control it a little bit more by just giving one cooler to the EMS supervisor for that region.
So back to the trauma centers level 1. So Dr. Kanaka shared this with me that in Chicago there we have 5 trauma centers. So Northwestern and then in Masonic, Cook County, University of Chicago and Mount Sinai. But there is some limitations of transporting patients that are IV going or starting an IV, because the requirement is you have to have at least an MD or medical physicians or an RN to start to monitor that transfusion. So my follow-up question is about, the question why is Illinois is blacklisted on the map? So we've always been blacklisted for a reason maybe, so and why are we catching up? Because maybe there, as Colleen said, there's probably evidence about mortality and morbidity of these patients that are hurt or needed blood in the field. So as we started to respond to this, so we need our collective effort to really understand and come up with a process as a group. My other question was, you know, it looks like the EMS services or the life and helicopter, they're approaching the hospitals. Do we have any blood centers in here, like, or is here universities right now? Are they approaching blood suppliers? I think that supplying the blood is not the issue, right? I think we can all supply blood
Yeah, Lifestar gets directly from Red Cross.
right across. Okay, that's good, because for the Naperville, I think their facility is closer to the hospital, so they just like, it's next door, so they're like, we want to get blood from you. So, Red Cross, are you guys providing?
We're getting those requests. We're getting those requests from Indiana. So in Indiana, we have a lot of EMS services coming to Versity and requesting to partner with us. And then they're actually rotating those units out. So yes, EMS is coming to Versity, to the blood center.
Yeah, Audrey Taylor, who was part of the team that wrote the standards, is out of the Gulf Coast, and they're supplying a lot of blood in the Texas area. Up in Wisconsin and in Milwaukee, Freighter is the biggest trauma, is the Love Trauma Center, and they are the ones that are issuing the blood there. So it's a mixed bag of blood center versus transfusion service. Again, you would have to be a pretty big transfusion service and have a pretty good inventory, so you were able to rotate those units down.
I just have a question. So, what is it about Illinois that doesn't allow us to be able to have this case? Is it state legislature that's holding us up? What is it?
Yes.
So it's a practice, it's scope of practice?
Yep.
Regulation, so they're not allowing anybody.
Yeah, the EMS, I talked with Dr. Gordy, who's the trauma doc down at Christ, and he said that Illinois was one of the first EMS services in the country. So it had always been local. The College of Surgeons licenses and approves most of the EMS services throughout the country, but Illinois, because it had that history, is a state specific.
So we have to lobby our state legislature?
Yeah, I think that's what it is, because again, I worry about Southern Illinois, Chicagoland area, we have so many trauma centers, but South, I don't know how they're handling that. I'll come talk.
First of all, I think that Ricardo, what you need is you need an MP to accompany the patient. I thought that. Okay, you said yes.
And an RN.
Oh, yeah, any medical professional that are licensed.
Okay, so, and my other, speaking from the blood center perspective now. When you say blood, I think you have to be a little bit more specific. That not every ambulance will get whole blood. Some of them will still get red cells and plasma, because I don't think there's enough whole blood from any blood center, and I'm sure to go speak about Red Cross, Vital, University, everywhere, to supply whole blood all around. Otherwise, you're not gonna have enough whole positive red cells in your hospital. So if everyone will want whole blood for their ambulances and helicopters and everywhere, so, you know, at some point, people will need to reconsider the different thing, red cells and maybe liquid plasma. Or something like that, you know, instead of whole blood. So we need to be a little bit of a mixed bag. So. just
Yeah,
that.
thank you. Yeah, that's a good point, and I think as you probably have seen already, we have more questions than answers. But it's just the questions that we have to help you start thinking of this process, right? We're not here saying, hey, we have the answers and that's why you're here today, but we have almost like a map. We know where to go, we just don't know what steps to take in that process, so just to get you thinking of that process, and if you don't have a process in place, maybe this will be the best chance to start something like that based on what we have said in the points that you brought up.
Thank you. I just want to add to something Ricardo alluded to and Yolanda asked a moment ago. So I've been, this is not a Northwestern thing. Yeah, it's not a Northwestern thing, but I've been working with the folks that are doing a lot of this Illinois push for pre-hospital transfusion. And they asked me to join their state chapter commission for this. And albeit that there's a lack of blood bank and transfusion input on this, it's all emergency trauma physicians working with regulations on their end. In Illinois, along with the state laws that limit the scope of practice for emergency medical care, in the city of Chicago proper, there is an EMS consortium run by 4 or 5 physicians around the city. And they kind of decide what the medical oversight decision-making and protocol is in the city. There is no single, Chicago Fire Department medical oversight person on their side. Much like other states like Texas and New York have hospital-based EMS or an EMS service with a medical director, Chicago is unique that it's sort of off-center from all the services. They decided they didn't want it for so long because of the density of trauma 1 and trauma 2 centers. But like Colleen said, it's not a matter of if but when. So the discussion is growing and growing. It needs more transfusion. Thank you.
What other questions? What other thoughts?
Just a comment to follow up on Dr. Kanakis. So, and this came up in AABB, the fact that you have a plethora of trauma centers, both level 1 and level 2, does not necessarily mean blood gets to your patient right away, because you have to factor in the amount of time it takes for EMS to get that call, for them to get there. So they may be 15 minutes from the level 1 trauma center, but it may take them 20 minutes to be aware that a patient needs blood. So by the time they get there, those minutes really are critical. Like Colleen mentioned, they were transfusion while extricating somebody. That may take a period of time. So there's still, just the fact that we have all these trauma centers does not necessarily mean that there's not going to be a need for field transfusion. Flipping gears a little bit, Colleen talked about emergency release. Who signs that? And there is a variation. The group from South Carolina, I think, said they have a physician who governs all those EMS transports, and it's that medical director who signs the emergency release. Lifestar said that they get the emergency release signed by the receiving trauma physician at the ER. Yeah. So they're making that decision in the field, really with no medical call. I mean, I don't know how they're making that. I shouldn't say no medical, I should say I don't know how they're making that decision, but the receiving physician is the one who signs the emergency release. So that's just a factor too.
Yeah, the other thing I have talked with some of the EMS folks, and because of Illinois being state specific, what I was told was that IDPH wants a plan. They want something written out, they want something formal as to what is gonna happen and how it's gonna happen. And until they have that and can review it and probably slash it 10 different directions and rewrite it 20 different times, I don't know how fast it'll be, but that is what they're looking for. They want a plan, so that they have something that they can really review.
The other thing is when you talk about training and competency, when I talked to the group from Virginia and asked who does your training and competency for blood administration and transfusion reactions, their response was they do. They competency their EMS the same way they competency them on everything else, starting an IV, administering medication. So there again would be a role for a transfusion service to step in and inform that training, because are they really, I don't want to say are they qualified, but will they really cover all the details they cover? And then from an accreditation point of view, if I'm like UCAN, University of Chicago, the blood bank issues blood directly to them because they have an RN on their helicopter. So I guess I don't think anyone from UC is here, but my question is, so if you get inspected, are they looking at the training and competency for those nurses on that helicopter? Now does that fall back to you? Like, are we responsible for our nurses training and competency when they come in? So do you have any idea?
Yeah, we have a transfusion safety. We have a transfusion safety officer for University of Chicago, and they handle the training and competencies for all the nurses. I believe UCAN is also falling under that, right? I believe so. Annual.
Yeah, I mean, a lot of times when we have inspectors, they come and they follow a unit of blood leaving the blood bank, so I doubt they followed it onto the helicopter and patient, but that would be an exciting trip, I think. So that's usually who they ask for competencies on, is whoever they follow up to the floor. I don't know if they go to that extreme of following the helicopter.
And I worry more about a hospital that is providing blood to an ambulance than a hospital who wants to receive it.
Again, it depends on who the, who the ambulance team belongs to, quote unquote.
I just, this is all new process for me, and so I'm pressing my
Oh,
way
yeah.
too, yeah, this is like, so the places that have the ambulances that have units of blood in the ambulance, is it all ambulances in that area, or is it only specific ones, like when 911 is called and they need something in the field? Is it only that specific ambulance company or hospital private ambulance that goes, or would all of them have? Yeah.
Yeah, that's a good question. I think it just depends on the type of setting. Some services, they do have their ambulances carry a set of units. And then, maybe at some point in time or at the end of the shift, they just kind of like swap them and rotate them, so they always have something, but I don't think it is, if it was like 20 ambulances, all 20, there might be just 10 of them and they just rotate, but it just depends on the type of logistics that they have.
Yeah, and again, I think the helicopters are very often, they know it's bad because they're sending a helicopter, so I think they almost always carry it. There's a comment over there, go ahead.
Yeah, so I can just kind of add on that. So University of Chicago, we do have a hospital-based EMS system. So we've got one helicopter and one ambulance. So those are the ones that are equipped with coolers. They have whole blood, liquid plasma, and red cells. So those ones will only stay within our network. They won't necessarily get handed off to another hospital. Does that answer your question?
Yeah, and I think that's part of the thing that would be helpful to not waste units if we have them on ambulances, that they have validated coolers, that they're transporting or keeping them till the next patient. We wouldn't have to leave the coolers at the receiving sites. We wouldn't be wasting those units, but it's not really a process right now because the EMS can't officially keep track of them. I don't know, Gale, when you have the helicopters, do they ever bring anything back, or do they leave it at they just cram it in before they get there?
They do, if there's anything, oh, sorry. If there's anything not transfused, they give it to the blood bank, but as I say,
Most of the
most
time
of
it's
them, we
going
don't have a process to evaluate that and bring that into inventory. I'm curious, do your hospitals ever return one to you?
Sometimes, if a patient's transported from another hospital, we've seen, units from other hospitals come with us. We discard them unless they're part of, once they're issued through our own blood bank and come back with the Aero network. I will add that we do have, temperature data loggers within our coolers. So you'll see a live reading of the temperature within that cooler, as well as, historical readings. So every time those coolers are brought back, we do download that data, so we determine if it's suitable or not to return.
Yeah, I think those APRU coolers actually have a digital readout on the side of them that you can see the temperature and graph, so you can see that it's been in temp over time.
So for the folks that have the process in place, I'm gonna ask the question about service agreement. Is the lobbying managing that agreement with the EMS or the helicopter? And then to what extent? Providing it, I'm curious about, charging, billing, that kind of stuff. Other than, you're supplying them. Anybody can share if they have a service agreement with EMS or what's handling that?
So I'm Kathy from the Red Cross. Of course, in Illinois, we don't have anything with any ambulance services, right? We do have the helicopters. They have an agreement with us direct. We do not accept anything back. So if it sits on their helicopter and they don't use it, it's their responsibility. Other places across the country, though, we do have contracts with ambulance services. Some of the ambulance services have agreements with hospitals where they could then return the blood to the hospital instead of wasting those units. So I had a call from a fire department in central Illinois who wanted to set something up with us, but he wanted to be able to exchange the units with somebody. Obviously, he didn't know that they wouldn't be able to transfuse the unit. But things to consider, like other places in the country, you either take it, you keep it, or you have an agreement with the hospital where you can do an exchange.
Thank you, Kathy. So to follow up on that, so if there's any issue with that, you can notify the EMS. Or we call it back, right?
Yeah.
Yeah. Okay, good.
Yeah.
So they should know who they
So
is.
the place that we sent the units to, and then they would be responsible for knowing where it ended up. Yep.
Thank you. I'm gonna pivot for a different question. So let's talk about the kids. So I know that, adults, majority probably are dealing with adults. Does anybody have any experience for pediatric trauma or anything for pre-hospital transfusion? I know in Illinois, there's only a handful of pediatric trauma centers. Any experience with pediatric kids?
We're level 2, we don't issue whole blood, I mean, we have whole blood at Christ, but we don't issue it to the pediatric patients. Our MTP is very confusing if you ask me. For the neonates, and especially the little ones, it's by volume, but we, from the transfusion service side, we send a couple of units. Andrea knows better than I do, but we definitely struggle with the pediatric side, and the limiting or the appropriate mix and everything else.
We don't want to leave them behind, so we want to.
I know.
Well, I just have an example that I found out about last week. There was a pediatric patient that came to Christ, that got transferred to Comer. We sent 2 units to the ED. We didn't know any better. Just last week, an RN asked us about one of the units' blood. Ended up, they put it in the ambulance or whatever and transferred it to Comer. We had no idea of that. So then I had to do a lot of background work to try to return a unit and discard it then because it was not given to the patient. So we had no idea, but they did bring it with the patient, not infusing to home.
I haven't seen Dr. Barrett just yet, but I don't know what really. Dr. Barrett, can you speak for a minute?
Yeah, I was gonna say, if Dr. Berger will be here later, if I can ask her if he has any more comments. So I know Lurie does get, has a helipad on top, they get air transport. They do get blood coming with the patient sometimes. If they're giving it in the, if they're giving it already, they'll just keep giving it. If they're not, their units, as far as I know, it's been a little while, it wasn't said to cover for the time, but as far as I know, they would discard the unit. They would bring you, they're supposed to bring units to the blood bank to keep a record of them. But then I don't think they use them, or at least as far as I know, they don't use them for anyone else there, but at least they have a process for bringing them to the blood bank, at least so the blood bank is aware of this, the unit came with the patient, and they do let the source facility know about it. That wasn't given, but we can ask, if she has more information, we can ask her later.
We actually collaborated with ILABB
Can you put the mic a little closer?
No, okay, I just worked with ILABB recently, because we are doing our pediatric MTV county is also level 1 pediatric trauma center, the same as General Hospital. So yes, we use all that for the pediatric MTV as well. However, we use full units. It's just that in the one, they have what called the peripheral chart. So they transfuse the blood before the patient's body. They approximate the body weight, and that's how they transfuse the blood to actually full units. So. The way share the policy with us, and then we couldn't quite understand some things. And then she explained. But regarding the brain hospital transfusion, we had a tentative request from the ambulance service in the county. However, and the EMS regulatory requirement, it's on hold right now.
Yeah, they all ask for it, and then you're like, can you give this? And they're like, what do you mean? So, yeah, they don't even know necessarily.
We think it's preferable to keep to a hospital than to a blood center. In terms of, keeping track of the units and everything, it's a better.
Yeah, it's not too bad if you own the ambulance service at your site. It's owned by your company, because then again, they register the patients because they're billing for the ambulance services and all the other stuff that they've done for the patient. It's a little more difficult if you're the one issuing the units, but the patient's showing up somewhere else. and tracking it and getting all of that testing and, you know, communicating back and forth. I think we're gonna be having everybody's phone number listed somewhere. Who should we call? And because where did the patient end up? I think it's gonna happen more and more.
And that's true, like, this was another point of discussion, like, you have to service, in Chicago area or the counties, can, dispute with patients, 3 trauma centers, like, in one is Northwestern, Mount Sinai.
Yeah.
Yeah, that's definitely this possibility.
Yeah, it depends on where they, how to be one. Yeah, you're okay. Dr. Craig's gonna come.
So for those that have talked with Heidi Gage about this, have they indicated any preference that they'd like to see in a framework? Or is it doing and
Do you know the FDA? Do you know how they get, I don't think so. I don't know. Has anybody got, I have, again, I just got it secondhand from one of the EMS folks, that we were meeting just to kind of talk with, again, our counterparts in the wage market that were already doing it. They actually asked them to present the information that they had presented at APB last year, about the pre-hospital stuff that they're doing. And they're just trying to get a group together to come up with a plan. I don't think there's any clear guidance right now. It's just, you know, gotta start somewhere and then kind of push from there.
So we have to choose life first. So it's the first 10 minutes of any emergency that dictates the patient lives or dies. So having sent a lot of blood from Indiana to Illinois and choppers, right? And knowing later that the patient lived because we're able to give the products, right? National knows. So what's the issue here? Does politics? So what, 45 states have the, and we,
You got it.
because you know that the most corrupt entity is the Cook County Municipal Politics.
How many governors in Illinois have gone to?
I'm not saying they're negative, but.
Yeah.
So who do we have to write letters to?
I'll try and find out. I'll reach out to my EMS folks and see if they have any, information. Cause yeah, it's crazy. It's like I said, it's not if, it's fun. And it's just, what do we have to do? Cause it does, it saves lives. It clearly does.
And I think it's the when, at this
Yeah,
point in
it's the
time,
when.
not if this will happen, so.
So I just following up on your comment, is it only Illinois where EMS is under the Department of Transportation, or is that a national?
No, that's a national thing that they're all under the transportation. It's just the approval process for Illinois is part of Illinois, whereas the other ones are part of the American College of Surgeons. So because we're kind of unique to that, we're not following the majority. Now, I don't know why the other ones, Iowa and Michigan and Maine, I don't know why they're not part, but maybe they have the same situation that they've always been doing their own state specific thing.
So, I'm just curious about, I don't know if the word would be repurposing or further manipulating whole blood into red cells. At some point in time, if we were to issue, whole blood. And then, what about the blood centers who are represented here? What would you say to that? Would you repurpose?
We do all the time. We get whole blood, we get it from Red Cross, we specifically get leuko reduced because all of our inventory is leuko reduced red cells. We couldn't get, from Versity, we couldn't get the pre-stored, the whole blood filter units. So we focused on getting them from Red Cross that were already filtered. We have a process, we do sedimentation, if they're a day or two before expiration, we hack them, check the hematocrit, make sure we meet the 80% in the requirement, and then we go ahead and put on the shot. Yeah, we're not gonna waste it.
You discard the last one.
Hospitalized.
All right, so
And
that's
the
actually a
computer
problem.
systems hate is, we basically have to throw the whole blood and recreate everything in the program.
So coming from the other side, so I'm actually from the Quad Cities, so I'm on the Iowa-Illinois border, which makes it difficult to send. We do send out just red cells and just plasma, so we personally don't necessarily supply whole blood. we have a location of our blood center in Missouri that I think is starting to supply more whole blood because it has more opportunities. As far as I know, no one is separating those products further. And for us, once the products are sold to those our Quad City location, we just sell the helicopter services because they have those registered RN, the flight nurses in there. We don't take any products back. It's interesting to kind of hear from the hospital side as to if you guys are getting empty bags or if you're getting those blood products, because we don't know what happens to them. About a third of what we prepare gets sold to a center, and then we just put unknown because we never hear from a location again. We keep segments just in case, but we never hear. But I think our Missouri location is starting to do more whole blood products. I'm not sure if hospitals are doing any manufacturing further from that, but it's difficult when we can't do EMS.
So if you have a look back or recall, you just notify the EMS service and it's their job to let you know if it went to a patient, or they have to follow up with the patient.
Yeah, so from what we validate in our process, we sell it to the EMS service or the area service,
Right.
what we call it. And then at that point, they give an empty bag to a hospital and the hospitals to dispose of the unit from there. But if we have any recalls, our quality department just contacts the area EMS service and just says, hey, wherever this patient went, you might want to. So we don't have any, it's kind of like once it leaves our facility, we don't want to know, but at the same time, I do, because I would like to know if it actually went to a patient, but
Yeah,
I
and I mean,
don't know.
if you're following the standards, there is that requirement to know about utilization and wastage. So if you're following and are getting accredited by ABB for that standards, you do need to know utilization and wastage.
So, Colleen, I'm gonna expand on that. So with this new standard that's gonna be effective, this is just my personal opinion, I think not endorsed by AAPD, but you have to be accredited by this standard. Correct? I don't know if you guys agree.
I don't know if there's not a requirement.
Because I don't think you could apply for accreditation yet. But if you do have pre-hospital processes existing now, my recommendation is to make sure you have processes and procedures.
Yes.
Right.
And I think, I don't know, Nancy tied in the back here, I'm gonna pick on her.
Oh, what we have to make.
I think as part of the inspection, will they be looking, if you are just following the BBTS standards, would they be including pre-hospital as part of that discussion?
Honestly, I have no clue.
Okay.
In mind, the AAPD standards, it's an elective accreditation.
It is elective.
So to follow the standards, you still don't have to be accredited. You could purchase them and follow them to the nth degree as you wish. You know, it's just the decision to be accredited for that activity.
Thank you.
Thank you.
So, I think it represents. CAP does not have specific requirements in place for pre-hospital.
It's coming.
You know, like comment on that? I'm sure we'll, with the ABB standards being promulgated, probably, well, some additional. Well, I've got the mic. If you're all, make sure you're aware of the ABB's forward working group, which has published a lot of information. There's stuff coming up in the near future, but I think include pediatric papers.
There's pediatric in there, there's also the giving the RH positive to our women of females of childbearing age. And if you've gone to the ABD meeting and gone to a floor session, they are passionate about pre-hospital transfusion, they are passionate about using whole blood, they are passionate about saving a woman's life. If given the whole whole blood that you have, save their life and worry about the RH stimulation after the fact. So definitely a group that is all about saving the patient, not the politics. They've worked very hard to get the push towards the pre-hospital transfusions, getting the standards written. It's been a really good group to really, for the betterment of the patient.
And there's a paper, I think it's from 2022 that the group put out. It is a nice regulatory recap. This was a great presentation, common thing.
Yeah.
But it's a nice reg
recap and a good overview of logistics of how to go about this.
Yeah, there's definitely a ton of literature out there. Do a little bit more research. I told most of the stuff that I pulled from the standards that just came out. But again, FDA requirements still exist and still apply. All of the other things that we're used to looking at, the CFR and the circular of information are still in play. So that's something that our EMS colleagues may not understand or care about. But that's the thing that we have to teach them. We have to be their go-to. We have to be the ones that are helping them to make this happen, because they're all pushing really hard for it. We just need to do it correctly.
And I think your point, sorry,
Go ahead.
very well made early on is for reg agencies, how can be very, very careful and specific as to how you structure your agreements
Yes.
with these organizations.
Well, and from a practical point of view, for any accreditation that you have, if you are issuing blood, that accrediting body has the right to follow that blood and the obligation to follow what the problems of that blood is after admission, whether you give it to an ambulance, whether you give it to a floor, whether you give it to one of your ambulatory sites. So whether or not you are worried about the ABP or CAP having specifics, if you're issuing it, you're responsible for it to the degree of knowing where it goes and how it's.
So, you're suggesting an ambulance ride or an ambulance?
No, I'm suggesting that your hospital giving it to the ambulance,
I'm just-
you have to have some structure in place to that. Because you're still responsible whether or not you're ABB.
Just remember, this has been going on for decades. You know, we have been issuing units to the emergency department and also I was telling Gunther this morning, I said, there was one time that 6 units of O&A went out of my department and came back in a brown paper shopping bag. So that's when I learned at that time that, you know, that EMS could not hang in the blood, and so it's the knowledge of the emergency room physicians and in the long run, no matter what, we'd like to control our units. But now with this whole push with low titer whole blood and everything, this is just the new hot topic of the day.
Yeah, it's definitely the hot topic.
The GPS tracking.
There's actually people putting GPS tracking on coolers. So yeah, go ahead.
So when you talk about like the responsibility of training people on the ambulance, right? I don't know about other states, but I know in Illinois, because I have paramedics in our family, there's a lot of private ambulance companies out there and they got a lot of turnover. Lots. How do you manage that? Like, I don't know how you manage that.
Yeah, and again, I don't know how many private ambulance services are requesting blood, but yeah, that would be a little concerning. I think the EMS that most people are talking about are really the county, the local fire department or the county EMS service.
I had one private ambulance company call me 2 years ago. So I think it.
I'm sure. Oh, yeah, if whatever's hot topic, it's everybody.
Most the fire department staff, they're gonna want to do.
Well, that maybe speaks to why they want our ends.
Yes. So, a lot of questions, not many answers, a lot of thoughts, things that you can think about. Again, Ignacio tried to put some of the thoughts and questions on the flow sheet, so take those with you. Come up with a procedure, share your procedure. If you have experience, please share it with others. We always learn best from somebody who's figured it out, and why reinvent the wheel. I always steal good ideas whenever possible. Yes, you have it now.
Yes, I have a comment, so this is where I might look to the ILABB. Could there be sort of a conduit or a forum for people to share their information? You know, if we're talking about, this is something that really is gonna affect all of us in one way, shape, or another. So does it make sense for all of us individually to create all these different things? Could we look to doing it as a community, you know, leveraging the ILABB, you know, now that I'm not on the board, I can throw them under the bus.
No, I think that's a really good idea. We'll have to talk.
I have one more question now.
Okay.
More questions than answers, right? So for those who are doing this, just on the FDA perspective, I know not all of us have registration. Is this something that you mentioned in your registration to the FDA, or you're not reporting it? I don't think FDA.
FDA does not call it out.
No,
But I have
okay.
seen.
I mean, there's not a separate reporting on the registration.
No, there's not.
Okay,
Give them another year or two.
just wanna make sure
But if you're a depot, you're supplying to someone else, there's a spot on there to.
you have to say you're a depot.
That we had to do that for Shirley Ryan, we had to put on our registration. That we were supplying blood to Shirley Ryan, a different institution.
Yeah, there is a box of checks for out of hospital, so the out of hospital piece is probably, maybe it falls under that realm.
Yeah.
I think there's gonna be a lot of questions at AEP in October.
Just putting it out there, not describing anything.
Just keep in mind that we're still here for the rest of the day. Let's do a lot of networking. You might have a lot of questions, we might have a lot of questions for you too as well, but just so you know, we're here. What better chance, right?
Yeah.
To ask each other or anything else.
One other thing would be, potential of, I'm not familiar with the side of things, but if we really want to approach the legislature about this, figure out where the communication would be, maybe our government offices.
Yeah, I'll try and see if I can get some
Yeah.
connections.
I'm
not sure who we need to pester.
Right, the one little detail I know is that our state representative, Robin Gale, is the majority leader of the House, Senate, Illinois House, she's an MPH at least.
Okay,
In terms of her background is regard to family health and so forth,
okay.
but they would have some, some resonance with her in this regard. So I
Yeah,
don't
no,
know.
I think it is a public health issue, because again, getting that unit there faster is always better.
And maybe we can get other support from the association,
Yeah.
You got the letter.
So thank you for letting us just ask our million questions, and again, think about it. We'll try and see if we can get some other groups together so we can share some of the processes and things that we come up with. But thank you for your time.
They have a long break now, so we'll be meeting at 11 o'clock.
Thank you, Ignacio. Here you go.
Oh, sorry.
Hey, hold on, guys. You gotta talk louder.
Oh, by the way.
Okay, all right.
We'll tell them once we're back and reconvene.
Well, do you mind if I ask
Yeah,
you to turn it up?
I turned, there's a thermostat there that I've raised a little bit. I don't know if it does anything. If you find staff I can confirm, then great. Yeah, that'd be great. Hey, how's it going, Joe? Good. Yep. How are you? Yep.
Sorry, I just really first time hearing that last time.
Oh, sorry. I was gonna announce it again when people sit back down, but basically the pace forms, just as people start filling them out, because we've been through a couple of these sessions, don't separate them, because the way they're currently laid out is only space for an attendee name on the front page, and if they get dismembered and people don't label them, then I won't know how to follow up with these certificates for continuing education. That's just it. Just keep the packet intact is the only thing that I meant to announce, and I'll mention it once I sit back down for the next session at 11, which will be Gale's talk.
Okay, is it okay to separate the workflow?
Yeah, the front page can come off, the agenda can come off, but like the pace packet, I keep that together.
Gotcha.
Yep.
Okay, thank you.
Sure thing. Oh, it's not this now.